speaker will introduce the innovation in interventional radiology, Dr. Bartal Gabriel, the chairman of Israeli Society of Interventional Radiology, and interventional radiologist and former director of the Department of Medical Imaging and Interventional Radiology at Meir Medical Center.
Thank you. Can I have my slides? אני לוחץ פה?
קודם כל הם צריכים להעלות לך את השיתופית.
I believe that all of you know what is interventional radiology. It's a subspecialty of imaging. It's a subspecialty of radiology, imaging. Radiology is, תודה. ועם זה, האם זה אני מעביר? זה קדימה אחורה? פה. ויש פה עכבר?
הנה, זה עכבר.
אוקיי, תודה. Okay. So I'm going to speak briefly about the future of interventional radiology. As I mentioned, it's a subspecialty of radiology, but now in some countries like United States, there is a different separate route to become interventional radiologists. In Europe and in Israel, we are still within the radiology departments working from there. But there's several problems with that, and which I will mention. זה לא עובר. עם זה? עבר? זה פה. אוקיי, תודה. Thanks. Basically, interventional radiologist is image-guided surgeon, and in some countries like in Russia and Eastern Europe, it's the specialty is called radiation surgery because they do these procedures, and we basically first of all we interpret the images for in our cases and monitor the outcomes of these procedures, and we can provide pre and post procedural care to our patients after the image-guided interventions. I have to mention that some of the procedures, like biopsies and ultrasound-guided procedures, are performed by general radiologists who are doing that in there, and by interventional radiologists in complex cases. So basically, vascular interventional radiologists, we name it as an interventional radiologist doing many other procedures I'll talk about in a minute. And the problem is that the clinical part is a problem. So we are skilled in diagnostic imaging, in invasive procedures, and the clinical practice. In fact, most of the procedures, including the cardiac coronary interventions, have been started by interventional radiologists, and then the cardiologists took it over, and they're doing outstanding job. So the problem is this, as I mentioned, with the clinical practice. So what are our challenges? First of all, we have to train our residents and our fellows, and we are now evolving with the use of simulators, and we are going to have a program, I believe, with African colleagues to introduce a cloud-based simulation, training them from either Atlanta or Tel Aviv or Beersheba, doesn't matter, and being in touch with them even during the procedures and guiding these young people who will learn and do their job, no question, outstandingly with the time. Problem with the workforce and clinical practice commitments. The problem is that some of the interventional radiologists have to interpret the images, reading CTs, etc. So it comes on behalf of the day case facilities. So what we need, we don't have inpatient beds. In some departments, we do have day case beds because most of the procedures they do not require hospitalization of the patients. And we have turf battles, competition with cardiologists and with vascular surgeons. So far, we're doing well. So this slide is coming from a friend of mine, Professor Haskell from Virginia. He's one of the leading persons. And what we have is imaging, procedure, and patient care. This is AR. And no future for interventional radiology without combined and innovation eye practice. And the relationship between the individual and the patient should be closer, and this is something we'll work on. So what is interventional radiology today? It's procedures. We do the procedures. Tomorrow, it will be contact experts. We should be knowledgeable and be able to do everything which is required. There is a new field, like 10-year-old field of interventional oncology. So there is no tumor, we cannot treat it without surgery. And it's a day care, patients going home the same day or next morning, okay? This is very important. Vascular interventions covering everything, starting from the aorta, carotids, peripheral, you name it, bleeding patients, pediatric interventional radiology, which is evolving field, women's health, embolization of the myoma, men's health, prostatic artery embolization, and varicocele treatment, gastrointestinal, genitourinary, and another new field that we have doing quite a lot, and several of our fellows who came back from training from abroad. It's musculoskeletal, either embolization or ablation. So if the patient, someone with painful knee or shoulder, we can embolize the vessels very selectively, and the pain is going away, which is really promising field and evolving. Now, there is a problem. We have to pay for what you do. And the payment is, you can see this on this slide, increased rate of health problems, starting from skin lesions because of the radiation, the scatter radiation, cancer, hypercholesterolemia, hypertension, cataracts, which is a big problem. Most of us have the cataracts in younger age than other population, but the main problem remains the orthopedic problems, spine, and you can see this slide shows very nicely. These here are the people who do not do interventions, and you see with the time, this is 5 and up to 16 years, the prevalence of orthopedic problems, mainly spine, is extremely high, and I am unfortunately a good example of such damage. You can see it here. Another observation, and already approved, Professor Aryeh Rogin, who was that time worked in Rambam, a cardiologist, now he's heading a department in Hedera. He found the following. It is a striking finding that disproportionate occurrence of the tumors, glioblastoma multiforme, left side of the brain, 85% compared with 50% in the general population who do not do it. So because the radiation, the scatter is coming from the left side to our brains, so we have to think what to do. Okay, what we can do. There are several solutions for that. In addition to the regular apparel we use, this is zero gravity, which is a very nice solution. There's no weight on the operator. The problem is, first of all, it's extremely expensive, very bulky, and takes a lot of space, and it's good for only one person, but there are several people working in the same room. The other options, this is Israeli company, ex-Israeli company. By the way, these guys, exoskeleton, these guys, there is a spaceship around the moon, and their equipment for the radiation protection of the people who will go to the moon and further on is made by this company. So we have this exoskeleton, and I hope that it will work. And you see, you can easily walk around having this complete protection, and there is no strain, nothing like that on your spine. And it is not clinical yet, but it is evolving already. So how can I move on like this? Okay, so Sam can. The key for this is the balance between the comfort and protection, and we have to be very careful balancing between these two. Okay, let's move on. The last but not the least in endovascular robotics, this is Corindus, and this is a microbot, which is basically it's a PlayStation. You can play with it, but it gives you, it's disposable, and you can do any procedure you like using the catheters and guide wires and balloons and stents, etc. So this is something which is evolving. Doesn't move. No. The future, again, different solutions, robotic-assisted procedures, remote capabilities, and analytics. And those are the examples of devices. Some of them already work, and some of them under preclinical, in the preclinical stage doing animal experiments. Just to introduce our society, we are national member of the ILSIR, European Society of Interventional Radiology. We already have 5 fellows and 2 distinguished fellows, and we'll have more. And we cover entire range of the interventions. Last but not the least, we made a survey that showed that there is high interest in the young residents to become interventional radiologists. So those are the challenges for upcoming 20 years. And one of the most important things that the personalized medicine will replace population medicine, and restoration will replace palliation. Thank you for your attention.
Thank you.